I think, Victoria, that is a wonderful segue to you now, if I may. I'm also curious, though it's not part of the agenda, what gives you hope? So if you are addressing us, please also tell us that, because I think it's important to have radical hope, not a kind of, rose-tinted hope, but a hope that actually, if we persevere in something, we can actually change it. So please do share with us your perspective from Kenya, and then we can end this part of our session, please.
Good afternoon, good morning for those of us who are joining us online. My name is Victoria, as you've heard, and I'm equally surprised that a lot of you know so much about FGS. Fast forward, or if we go back 5 years ago, 1 year, 1 month today, we sat in a conference hall just like this, and we were trying to figure out what is this FGS to start with, and what do we need to do to make it more mainstream? Because as we all know, FGS, the first case of FGS was known in 1899. Quick math, that's 125 years ago. Some of us are knowing it now, but don't worry, you're in the right place. We'll teach you about it. So as we summarize, I think I want to give it in 2 pieces so that to answer your question. The reason why we are here is just to try and make women's health integrated, because we all know, as Dr. Atul has said, all this presents like a similar PID, STI, and all those things. So what is our role in now this journey? And I think I don't want to speak too much into that so that I release you. Then I can come back to the next step. So our why is to make all this accessible to the women and girls that we are serving. Thank you.
Thank you. No, please.
Sorry. I can continue?
Yeah, please.
Ah, okay. Thank you. Back to my speech. So 24 years ago, when I heard the word gynecologist for the first time, I wanted to be it mainly because the first thing, it sounded complicated and sophisticated. So I wanted to be that just mainly because of the name. But the second reason that brings hope back was because I also wanted to be the best friend to a woman. But that said, I didn't envision myself 17 years later sitting in front of a woman. And most of the time, they used to come with advanced cases of cervical cancer. They come with infertility, recurrent pregnancy losses, and they were mostly at their worst spaces. And at that point, even with my knowledge as a gynecologist, I mean, we do the hard stuff. I couldn't offer more, any other intervention. The best thing was, I'm sorry that this is going on, but there was really nothing much I could do. But as I went along, some of the 4 questions that kept me going through and revisiting this process, when you look at the different diseases, but the 4 questions that they kept asking was, what did I do wrong? How could I have prevented this? Can it be treated? And number 4 was, how can I make sure everyone in my family doesn't go through what I've gone through today? So when you hear those 4 questions, I don't know whether you're hearing these women trying to talk to you and asking you that same question in your same place where you are, because you can see that these women have been coming to the hospital, they've been coming to the various centers, but we are not giving them what they need, because as Atul had said, we are fixated on, I work in family planning, or I work in cervical cancer screening services, or I work in whichever spectrum that you're doing. So at that point, when that lady is in front of you, you're at least bothered to really tease out what they need. And I think coming together as a whole, we're trying to say this. FGS, as we've said, is a chronic disease caused by a parasite, and it presents non-specifically. And it can cause all these complications that we're talking about. What we're trying to do is build an integrated response of healthcare workers who can have that foresight to actually have that high index of suspicion to say, you probably could have FGS, and this is why. And I'll tell you how we started in Kenya. In Kenya, 5 years ago, we didn't have any prevalence or baseline levels of female genital schistosomiasis. But as we moved along, we just went with one thing. We knew that these areas are endemic for schistosomiasis, and if we went with the right skill, with the right knowledge, we'd be able to actually get these women and girls where they are. And as I would say now, we've gone to 3 different counties, we've gone to 9 facilities, we've gone through 4,600 women have been screened for FGS, and out of that, 660 have actually been positive for FGS. So we're changing lives no matter how small we are, but we're giving them hope, because when you listen to their stories, they actually come and tell you, I was at this point. I usually call it a relay race that we're in. They first of all come to the primary healthcare level at the community first before they actually leave the house. You have to ask for permission from the husband. And now you can imagine you have recurrent discharges, you're having pelvic pain. What goes around is you definitely have an STI. So how do you even ask your husband for permission to actually go for treatment for that? So before that, that's the first journey they have to go through. Then once they go to the primary healthcare level, without the knowledge, without the skills, you definitely can't diagnose FGS. So then they go back, they're treated for STI. The second time they come around, you're probably, if you are in my space, you'd probably say, probably that antibiotic didn't work, so this time we're going to go for an injection, the whole spectrum. Then they still come back again. Now you can imagine that face of that woman having to undergo all those different types of methods of treatment, and it's still not working. And then by the time they come to me in the referral facility, it's too late. They have advanced diseases, they have advanced cervical cancer, they've probably gotten the HIV. We say FGS increases their risk of HIV and AIDS up to 3 times. So it means we've really missed the mark. We've really missed the mark from the point go. And this woman was there with us the whole way. They kept coming, but we sent them away. So what are we trying to say in a nutshell? We can change this. I think you can see from the 4 questions that are posed that these women are actually asking, what can you do before all this comes? And that's when we don't normally do it in terms of investing in women's health. We are more into how do we treat? But these women are asking you, how can we prevent this from the start? And this is where now we can work, all of us together, because it's a development issue. I'm sure the number of times I've looked at the water bodies when we go to any of those hospitals, I can tell you with my medical knowledge, I really don't know how to make that water safe. But when we ask our development partners, you probably can help us to make it safe. So that said, we all have a role to play in this journey of ending FGS. And before I leave, I just want us to say female genital schistosomiasis in full, because I know I am a trainer, I am a teacher, but I know most times most people it's a tongue twister. So please, if I may ask, can we all say female genital schistosomiasis? Let's start. Female. I didn't hear that. The last part, I didn't quite hear it. Please, I didn't quite hear it quite well. Just say schistosomiasis.
Schistosomiasis.
Are we going to end it?
Yes.
Thank you.
Thank you again to our speakers. I bet you didn't expect when you came in here today you will be rehearsing the words schistosomiasis. When you see Dr. Gamba in the hallway, she will prod you, so please be practicing it if you remember. Thank you again to all of our speakers. You may please leave the stage. Please give them another round of applause. All right, wonderful. Okay.